Thank you for coming. As Anton said, we really just moved into this building and we're pretty excited and proud about it. So we've, I think, done maybe one other sort of external event in this room. So it's kind of new territory and we're all just kind of feeling our way. If you get a chance to take a tour, there's some actually pretty cool things going on in this building and different architectural design. This is a Jack Diamond building and he's pretty proud of it. The wood and the glass kind of reminds you of the Opera House a little bit. And that's not by accident. Actually, this wall here is all glass. And if we raise the blinds, you're looking outside, which is kind of cool, but doesn't work so well with the slides. So we'll keep the blinds down for now. So Anton, thanks very much for giving me an opportunity to talk. And the title of the talk is Quality 101 to Quality Number 1. I'm really reverberating. You're working on it? All right, so I'll just keep going, but you need to do something. So I guess I'd start by saying the world has been involved in quality improvement for over 30 years longer, right, except for healthcare. And the government's all given us a little boost here by last June, legislating the Excellent Care for All Act for all of us to get involved. And that was all party, right? All three parties supported that legislation. I think it went through the House in record time. So regardless of who gets elected in the fall, I don't think this one's going away. So it is our time to get going, I would suggest. And these are two quotes that I've stolen from Min Alican, who gives talks about access and flow, uses these quotes, and she always puts them at the end. I thought it would be kind of cool to put it at the beginning. Every system is perfectly designed to get exactly the results it gets. Interesting to think about that. That's Paul Batalden. He's one of the originals of the IHI, so he's been in this business for a long time. He's at Dartmouth. And then we cannot solve our problems with the same thinking we used when we created them. Albert Einstein. Again, sort of interesting to think about when we think about what we do in hospitals every day. So the title of my talk is From Quality 101 to Quality Number 1. Do you want me to switch? I do. Because this is not good. Okay. So the title is From Quality 101 to Quality Number 1. So I only take credit for half of this, and that half is the Quality 101 piece. And Anton stuck the other piece on the end of it, so I'm not sure that is really mine, but the whole thing sort of played better, I guess, Anton, so thank you. But there's a reason for this Quality 101 thing, and it's because I actually started in this business about 5 years ago when I had another job here at St. Michael's, and I was given the task of fixing Emerge. So we had, ambulances lined up around the block. We had 20 to 25 no-bed admit patients in Emerge all the time. All the time. We had the worst data in the province. So Bob, you go fix. I thought, okay, well, roll up your sleeves, get at this, and we'll get this one done. And 2 years later, abject failure. So I worked at this hard for 2 years and got nowhere. Nothing happened. Nothing got better. And then we did some things and had some ideas, and we actually started to move it, and the numbers started to get better. So we started to reflect on that. But I knew that I was a neophyte, and I really didn't know what I was doing. So I went to the IHI, talked to people from Kaiser Permanente, places like that, and said, look, you guys know how to do this. Help me. How do you start? How do you start? Give me Quality 101. And they all looked at me like I had two heads, and I got the sense that they'd been at it so long they forgot about how to get started. And they were so far ahead that I didn't necessarily think that what they were doing was helping me, because I was really just trying to get started. I wasn't trying to be fantastic. I just wanted to get moving. So I've been reflecting as we've been going along. Well, what is Quality 101? Like, how do you start if you haven't been doing this in any kind of real way for a while? So I got some thoughts about what that is, and I'm going to show you give you the St. Mike's experience to give you some data and maybe something to talk about after. So how to get started? And I guess the first kind of little thing for me, and these are all kind of lessons learned or things I think are important, and you may or may not agree. You can tell me afterwards. But the first one on quality improvement, the important word is the improvement word, not the quality word. Because it really says things need to be better, things need to be different, therefore you have to change stuff. So the same old ways, remember this, the same old ways you did it before, if you're going to do that with feeling, that's not going to do it. You actually have to fundamentally change. So that's a pretty important principle. So the principles of change management suddenly become crucial. So here, I put something up here. So there's a book that John Cotter wrote in 1995, right? So probably a lot of you have read it. It's like over 15 years old, still stands the test of time. And what he does is on the right-hand side, there are the 8-stage process of creating major change that he talks about. So I think that's actually really critical to think about that when you're thinking about how are you going to get started in quality improvement, because we're talking about change, right? Changing your institution. So his 8 stages, I think, are important. The problem with it is it's 8. And so I have this view that you can only remember 3, right? It's not possible to walk around with 8 in your head, so pick 3 and go with 3. So on the left-hand side, Bob's 3, right? So I've lumped Cotter's stuff into make the case, get going, and then you got to make it stick. And you can sort of look at what he's saying, develop the vision, communicate the change vision, establish a sense of urgency. For me, that's all about making the case with your staff. Get going is, right, well, you got to create a guiding coalition. You got to have some folks that are leading this. You need to empower people to change. You need to get some wins. You need to get some successes and then build on those successes. And then you got to make it stick. You got to consolidate your gains, produce more, and then anchor it in your culture so it becomes part of who you are. So that's Cotter, but make the case, get going, make it stick is maybe something you could all remember. So that's the first thing. So sort of walk through the thing. So what do you do to make the case? So I guess for me, and when you hear the NHS people come and talk, they talk about this. You got to capture their hearts. It's not just the minds, the hearts too. You got hearts and minds on this one, right? So if you go out there and sort of make the data case, that's not enough. You actually got to tell the stories too, right? The individual stories about individual patients that didn't get the care they deserved. That captures the heart. So in making the case, you really need to think about data and stories, and actually good and bad stories, because I think you can talk about that. You have to be very careful about what kind of story you tell to who. So I'm always telling bad stories to the board, and I'm more likely to tell good stories to the staff. The bad stories to the board is because boards tend to think we're doing great things, and so they're not engaged, right? They're sitting back, everything's wonderful, and when you tell them about a bad case, all of a sudden everybody's sitting forward on their chair, everybody's involved. The staff, all of our staff, think that the patient's the most important thing in their lives, and when you tell them a bad story, it is depressing. So you have to be careful with how many bad stories you give them. If you tell them good stories, you elevate everybody, but you also sort of quietly set the bar very high. Like, here's what we expect. Somebody did something amazing. You can all do that. So I think you have to think about your stories. In terms of capturing people, I think there's no question that we need to change. So we all know about system errors, and down there in the corner, to err is human, 1999, right? Not that long ago when that book came out in the States, showing all the deaths, the preventable deaths, and then Ross Baker and his group here in Canada, the Canadian Adverse Event Study, 2004. So not that long ago, but it's pretty clear that we're harming patients every day in this country, and we need to do better. But there's also data about variability. ICIS publishes data all the time to show you variability across the province. I mean, variability means opportunity for improvement, right? There shouldn't be that much variability if we're excellent. And then inefficiency. To convince people that we're inefficient is actually easy. One way is to say, how often do you hear a patient telling you that, or asking the question, how come my history had to be taken 7 times when I was admitted to hospital? Because that's true. That happens all the time. That's rank inefficiency. And what that says is we never designed the care that we give so that you could take one person could take the history once, put it on a chart where everybody could get it. It would have all the elements that were necessary for everybody to have, and we'd move on. That'd be 6 people that didn't have to waste their time taking a history. But right now it's 7, and so that's an example of inefficiency. There are lots of them. We can do better. So making the case shouldn't be that hard, but you have to think about it. Getting going, so that's number 2. So I've thought about this one a lot, and what I've done is stolen again from the IHI, and you see down in the right-hand corner, the Institute for Healthcare Improvement, 7 leadership leverage points. So that's a white paper they produced quite a while ago. So everybody should read that. It's actually really good. And when you think about that, what's in that, it helps you to think about what you got to do to get started. The problem is it's 7, right? And you can't remember them. So I've boiled it down to 3. Rule of 3s, right? Leadership, structure, infrastructure structure, and engagement. And I'm going to talk about each one of these things. And if you look at the IHI paper, all of their 7 fits into those 3 with a little bit of license, right? So what about leadership? So this is something that, this one's not that hard. Every leader in the hospital has to be engaged in the change process, from the board through the CEO, down through the senior team, frontline management. And don't forget taking advantage of the opportunities given from roving leaders or local champions who are not official leaders, but are unofficial leaders and can have a huge impact on this. You need to take advantage of those people. But for me, this is the key. If the CEO is not all over this, it's not going to happen. It's just not going to happen, because everybody listens to what I say and what I don't say. So if I talk about quality improvement every time I get up in front of the staff, he must be serious. If I don't, they say, hey, he didn't talk about quality improvement. Maybe it's off the agenda, because there's lots of stuff on the agenda, right? So I strongly believe if the CEO isn't all over this personally, it's going to take a long time. Structure. So leadership, structure, infrastructure, and engagement are the 3 parts. So I put a slide up here on governance, and I'm not going to talk about this because Kevin Smith at a previous one has talked about governance and quality and gone through this in a much better way than I, but just as part of structure, you need to think about how you structure. Every hospital now has a board quality committee, and there's MAC and hospital operations, and then there are quality committees that report into that. And I would suggest that as an institution, you kind of have to have that in place. The one thing I would add is you need to figure out how to get those 2 groups talking to each other before it gets to the board. That's useful. So doc alignment is a big deal on all of this. So there needs to be ways, and maybe there's a way to put an arrow between the bottom 2 or whatever, but just to put the thought out there that doc alignment is absolutely crucial, and you need to spend time thinking about how that's built into your organizational structure. This was one for me, this was the secret sauce for me in terms of when we started to have success at St. Michael's on access and flow, is I had no infrastructure in place to support change, none. So I was using people, directors, managers who had full-time jobs and bringing them into a room and sort of beating them up and talking about how we need to do things differently and we need to go on a different path, and then 2 weeks later bring them all back again and do it again, and everybody was on board and everybody was keen, and nothing happened. And the problem is somebody's got to do some work here, right? And these people have a full-time job, and by the way, it isn't a job that's driving change, and frankly, they actually don't know how to do it. So if you look on this slide, what we've done, what I would suggest needs to be done is you obviously need somebody to lead quality. I think the CEO has to be all over it, but maybe there's another person who's kind of the quality lead. But you need a quality office, if you like. And within that office, if you're going to do real change, you have to have some infrastructure, and I mean people. So these are people, for the first thing you need to do to make change is you got to have data. And it's got to be as close to real time as possible. If you can't measure it, you can't manage it. So if you can't measure it, you don't know what it is to start with. So if you change it, you don't know if you changed it. So you have to have data. So any change you want to make of something you can't measure, forget it. Don't do that. Only change things that you can actually measure. And you have to have people that can analyze the data. You have to have project management kind of skills. And you need people that know something about process redesign. And that's kind of AKA lean. So we don't use lean. So my bias, lean is way too expensive. I don't want lean. It's too expensive. And we got way too much low-hanging fruit to need lean. But there are all kinds of process redesign models you can use that allow you to change your models. And you don't need to spend as much money as lean often likes you to do. There's nothing wrong with lean. And I think as we sort of climb up the tree and the fruit gets farther and farther away, you probably need more sophisticated tools. Lean would be one. Six Sigma would be another one, like way up the tree. So they're good, but we're way down here. Like you can pick it, right? You don't have to get a ladder. The other concept I want to put here is the notion of tools. So I strongly believe that no change happens without the development of a tool. And the tool is what allows people to change. So if you go to a ward and say, okay, we're going to do things differently, it's like, well, what? You come with a tool. I'm using the term relatively broadly, right? It's some sort of, it could be a checklist is a great tool, but it's that kind of idea. It's something that says to people, this is your job before, here's your job now. And the tool is the new job. And everybody involved in whatever that process is on the tool, and everybody does what the tool says, and now you're doing something differently. So it's the development of tools. If there aren't tools already out there that you can sort of buy or steal, that is what's crucial, and that's why you need people, because frontline staff can't make their own tools. They can't do it themselves. They have to be involved, but they don't have these skills that allow tool development. So for me, this was crucial to allow us to actually start to change, is to have that skill in-house. Engagement, leadership, infrastructure, structure, engagement. So this is just to say, this is a frontline staff game. So anybody that set up a quality office, it's over there, and if you go to the frontline staff and say, okay, how does quality happen in your office? You say, oh, we don't do that. That's that. They do that in that office over there. They're dead, right? Because this is all about frontline people providing care differently, doing their jobs differently. Remember, it's all about implementation means change. So frontline staff have to be fully engaged, fully. So you cannot take the responsibility away from them. They have to feel the responsibility for this. And I've got stories about things that happened at St. Mike's that kind of gave me the idea, or the realization, that frontline staff didn't feel the responsibility, and we had to change that so they did. So you have to do stuff. You know, they have to be involved in all this stuff. There have to be working groups, committees. You have to encourage them to come up with their own ideas for change. You have to provide educational opportunities for them so they kind of understand what this thing is all about. And you have to communicate like crazy, and you have to really trumpet your successes and create some excitement about doing things differently and better. So leadership, structure, infrastructure, engagement are the three aspects that I believe let you get going. If you don't have this in place, my view is you're never going to get going. So I put this up next because this is just a little concept for me, and it's really simple, but I think it's important. And it's a little 2x2 matrix that says that not all quality improvement is the same. Some of it's relative, and I don't want to say easy, less difficult. And some of it's damn hard. And some of it's in between. And I think as leaders, you need to think about that before you kind of jump into an initiative for change. So, and I think what's important is whether the initiatives are local, meaning, you know, in the ICU with a few people, or right across the organization. So that's one metric. And the other is whether there are already valid tools, already, out there in the literature. They've already proven to work. You can just go get them. The surgical checklist is a great example. Or whether there are no tools, you got to design your own. So when you put those together, clearly the easiest thing to do is to do something local with a tool that's already exists, that's already been proven to work. That's quality you should do, and everybody should do all of those, obviously. And then, of course, the hardest one is where it's corporate and there are no tools. You've got to invent everything yourself, and it's the whole organization, lots of people. And then everything in between. And I think you should always have these in mind when you're kind of thinking about what to do next, right? Because there's always decisions you have to make about how many of these things can you handle in a year? And you need to think about, well, what are they? What's the impact on your organization? So St. Michael's. So I'm going to show you some things that we've done. So those are sort of general principles of what I think might be useful for you folks to start up. And I'll just bring some St. Mike's reality to this to show you what we've done. So on the make the case part, so as I said, I started doing what I didn't actually know it was quality improvement. I was doing wait times in eMERGE stuff 5 years ago, but when I got the job as president, I made quality immediately a priority. I'd figured out in the interim that actually wait times was part of quality, and so I was sort of trumpeting quality. Communication is a total priority, and I started talking about quality at every meeting I was at. Didn't matter who it was. And I talked about it every time until people were sick of hearing me talk about it. And I'll come back to that in a bit. But one of the things that happened was, as I talked to people, and I kind of see their eyes glaze over this, quality, and they just kind of, oh God, we've been hearing about quality for like 20 years, right? And it occurred to me they actually didn't know what I was talking about. Like they didn't actually know what quality was, or if they did, they didn't agree on what it was. They had different ideas about what quality was. And my sense was, well, I can't get them engaged unless we're all talking about the same thing. So at St. Michael's, we define quality. The easy one, the one that gets everybody in, is safety, right? So safety is, there's nobody who works in a hospital that doesn't want their patients to be safe. To induce harm is the last thing that they want. So if you say quality is safety, we're going to make our hospital safer, everybody signs up. I'm in. No argument. It's the easiest one. Outcomes. If we give you a new hip, it should work. Pretty easy to accept that one. Access. Well, I've already talked about that. It's not okay to be in eMERGE for 3 days waiting for a bed. That's not good care in any way, shape, or form, right? So access is a quality measure. P for patient experience. Could have been an E, but I needed a P. You'll see why. So we should treat our patients really well. I mean, we actually go a long way. If you treat your patients well, you can hurt them and they don't complain if they like you. So treating them well is actually important. The patient should, when they leave your institution, they should say, that was a fantastic institution, great people, they really treated me like a human being. That's quality. In Canada, equity is important, and certainly in my hospital, you cannot stand up and talk about quality and not put equity on the list. We have a really diverse population that we serve in downtown Toronto. It's very important to think this one through. And efficiency. If it costs you 3 times as much as it should to do something, that's money you could have spent on something else that you're not doing. So you should be efficient. And the patients want you to be efficient. They don't want to be hanging around waiting for stuff. So efficiency is quality. And these are all from the IHI. So if you look up the IHI, 6 dimensions of quality. I've taken a little bit of license with their name, but these are what they are. So I didn't make these ones up. The IHI has already decided that these are the 6 most important ones. So I adopted these at St. Mike's. And of course, it spells SOAPy. So you don't have to remember 6 things. You just have to remember one thing, SOAPy. And you can go out there and say, oh yeah, SOAPy. Every person, so I've talked about SOAPy for a full year. Everywhere I went, we put it in newsletters before people actually finally heard it, right? So it's amazing how long it takes this stuff to diffuse out. You know, go to a little meeting with the president or whatever and say, how many of you guys heard me talk about SOAPI? And like no hands would go up, and I've been talking about it for 6 months. Nobody heard, right? Now, if I go to a meeting, I say, who hasn't heard me talk about SOAPI? And there's maybe, you know, there's usually a couple of honest guys that'll put their hand up, but basically everybody's heard. And they like it because they see where they're in it. And you don't have to be a nurse to be in this, right? The housekeepers are in. Transportation, you know, the porters are in. The engineers are in. They're all in. And actually, I knew I'd made it because this year we have Halloween skits. And the different groups in the hospital put on little skits at Halloween, you know, jokey skits. Every one, I think, was on SOAPI. They all made fun of me and SOAPI. So I thought I've made it, right? They're making fun of me. We're there. So what about the structure at St. Mike's? So this is our governance structure, and I guess this mirrors what I've already showed you. What's different at the bottom, on the right under the hospital, we have a senior management committee, and we have a council structure that reports to senior management, and there's about 6 or 7 councils. 2 of them relate to quality. One is the Quality Council. And we also have a Clinical and Financial Outcomes Council, which is really kind of about the money, but efficiency's in there. And both of those councils report into senior management. So that's our sort of governance for how we report this stuff up to the board. But we have really strong links between MAC and senior management. So just so you know, I'm invited to every MAC. All of my senior executive team goes to MAC meetings, every one. So we're there, and on senior management, there are three docs, plus the CMO, 4 docs on senior management, like full-time members. So we really work hard on this alignment piece. This is the important part, the implementation part, right? So who's doing the work for this change? So at St. Michael's, the EVP and CMO is the quality lead reporting to me. And he has 2 groups of people that report to him right now. One group you could put under the safety bucket. So there's a director, there's a medical director, and there's some staff. You know, I put infection control practitioners in there because infection control is a big part of safety, and that is all in that portfolio. And we have an access and flow portfolio. This comes out of my history of failure for 3 years, and we put a group together to provide some change infrastructure for access and flow. And so we have a director, we have a medical director on this, we have some data people, process redesign people. We have a real team here that just works on access and flow, developing tools, developing change tools with frontline caregivers. And then we have on the EVP Chief Administration Officer side, we have a process redesign office that we put in place a few years ago. We took some money out of the budget and hired some process redesign type folks, and we put them in places looking for efficiencies and redesigning how things happen to gain efficiency. So remember, it's the second E in SOAPI. It's part of quality. So all of that reports up to me. So this is work gets done by these people. Can't emphasize that enough. So, but one of the things I wanted to add here, and this is something I learned at the IHI. When I went to the IHI and said to them, you know, like, how do you do this? And how, you know, we talk about SOAPI, you guys don't talk about anything. You just talk about quality. Like, what's your problem? Like, how do you actually get away with that? And what they said to me is, well, because we're only doing safety. We're actually not doing all of the elements of, we're not doing all the dimensions of quality. We're doing safety. So if you look at every hospital in the States, they're all doing safety. They don't do access, not much, because they just, you know, a lot of them are for profit, right? So they're actually trying to pull patients in. So access and flow is of less importance. Safety's the one. Patient experience is another, in terms of pulling patients into your institution. So they don't talk about it a lot, except they're all doing safety. Their advice to me is, don't do all 6 deep and hard. You got to pick. Pick your spots. The principles work for everything. They're the same. But you can't do everything all at once. Pick something and go after it. So we picked safety. We were already doing safety. We picked access and flow, and we picked efficiency. We're doing outcomes, and we're doing patient experience, believe me, and we've got some good work going on equity, but I don't have much resource on it. You know, the infrastructure piece where I've got all those people, they're on safety, access, and efficiency. That's where they're focused. They're not focused on the other ones. Doesn't mean we don't have some small initiatives, but we're not deep and hard on those. And that's the message here from the IHI, and I actually accept it, is you can't do it all at once. You have to pick your spots. They actually would argue that maybe 3 is too many. So now I'm going to go back to my little construct and give you some examples of some things we've done. So here's our 2x2 matrix. Local, valid tools, easiest, right? So I picked ventilator-associated pneumonia as an example, right? So there's a tool. It's out there. It's been validated in the literature. All you have to do is implement it. And obviously, you're only going to implement it in the ICU, right? It's not a whole hospital thing. So it's a small number of caregivers that have to buy in and get going. So we did. So here's our data before. So our, average incidence of ventilator-associated pneumonia was sort of somewhere around 8% per year. It's interesting, right? 8% per year, the staff don't know about it, right? That's actually low enough that nurses at the bedside don't actually know there's a problem. Because they don't, you got to be a nurse and go a whole year and not have one. But you see what happened. It goes down, and it went down to sort of around 1%, and now it's like below 1%. So you don't know about this unless you look at the data, right? So this is why data is so important. You can't see it without the data. Frontline, so you got to show this to the frontline caregivers, right? You guys are like 8% per year, 9% per year. Now it's less than 1%. Thank you for doing what you do. By the way, keep using the tool. Don't slip. But this is kind of an example of low-hanging fruit, right? Just do it. So I'll show you another one. Timely prophylactic antibiotic usage. So here's an example in the operating room. Coronary artery bypass surgery patients getting timely, so within 1 hour before the surgery, right? Like not an hour and a half, that's outside, and obviously not after it starts, but within that 60-minute window, getting the antibiotics given intravenously. And you can see where we were. We were kind of hovering around 86%, and now with the new tool and in place, it's up there just under 100%. Now this is a process measure. This isn't an outcomes. This should translate into fewer infections post-op, but a little harder to measure. So this is an example of a process measure that everybody believes makes a difference. So what about local initiative, but you got to create the tool, because there aren't any tools in the literature out there. So here's an example. So one I've picked to show you is OR first case start on time. So anybody who has an OR knows that you can't, if you book your cases for the day, you start at 8 and you end at 3:30. If you're ending at 5, you're paying overtime every day, right? It's a problem. Or you're canceling the case, push it tomorrow. So starting on, if you start late, for sure you're not going to, you got a problem finishing on. So starting late, you're screwed right off the bat, right? So starting on time is actually pretty important. So here's some data. Our target was 90% OR first case start on time. So the blue line is 0809. And you see we were never, I think we got to 90% once, but we were trending below. So then we put some initiatives in place after that, and you see the red bar, the red line starts to go up, and then the green line is kind of where we are most recently. So mostly we're over 90%, but it fluctuates around. So I would say this is an improvement. I mean, it's trending up in the right direction. But this is a situation where we had to create our own tools sort of around the operating room to get this one done. So this is more difficult than ventilator-associated pneumonia, but again, not maybe an example of the most difficult. How about a corporate initiative where there are tools? So for this one, we picked HSMR. So HSMR is obviously some data we get that defines your entire hospital. So we did some things with that here at St. Mike's. This is the curve. So St. Mike's is the dark blue line. the other lines are actually other hospitals in Toronto. So everybody's actually improved on this one. But our blue line, obviously, around 2007, I guess that is, starts, 2008, I guess, starts to improve. So we did a number of things to make this happen. So the first thing was, and Chris Hayes is here today, he's in charge of the medical director for safety, so he is one who is on this and has presented on this. We took the we didn't wait. The first thing is not to wait for the CIHI to give you your data. Like, do your data every month on your own. And the second thing is break your data down and give it to the individual programs. So in this case, we broke it down. We have 6 major programs. We gave each of the program their individual data like almost in real time. The next thing is we required them to do chart reviews on every death and look in that for opportunities for improvement, right? So there are 2 things that happened. One is we found that there was often coding problems. So instead of being, it wasn't a preventable death, in fact, but coded incorrectly. So that changes things. But then the other thing was we found issues that were obviously needed to be fixed, and we could then do a corrective action, like almost in real time, to make things better. And our data has been trending down and down and down every time we measure it. So we actually took something that was actually corporate and made it local, I suppose, to make it easier to do, and had some success. So what about the top right corner? So I put it up there, right? So I think if the government knew what they were doing when they picked emergency department wait time as something that they wanted to put out there as a fix, if anybody could have advised them and said, like, don't do it. It's the hardest of the hard because it affects the entire organization, right? It's not about the emergency department, right? The hardest part of it is the part where it's the time to admit, right? I mean, the discharge home, if somebody's got a cut or a bruise, you can fix that. But the time to admit is brutal because it requires the whole hospital to change what they're doing, right? If you can't get them out, you can't get them in. So everybody has to be working to change their practice, to make it faster, and that's hard. And there aren't tools. You have to invent your own tools. So this is absolutely the toughest. So I'll show you some data. So I created a whole team on this one, right? So I've got a director, a medical director, I got a bunch of staff, we spend a bunch of money, and they create tools. And they work with frontline staff to change practice, right? To get patients out quicker and move them, pull them up from emerge instead of pushing them up from emerge. So here's some data that shows, remember I told you 5 years ago we were the worst in the province. These are patients, percent of patients waiting longer than 24 hours to get a bed who are from emerge. So they're admitted and they got to wait longer than 24 hours to get in a bed. And you can see where we were before the red line. We're up there, often over 6, 7%. Huge numbers of patients lying in emerge. And we put, and that's where I'm working on it, right? And failing. So we put some infrastructure in place, started to redesign our processes and work with frontline staff on the wards. It was all back-end work, right? This is not a work in emerge. This is back-end work, getting patients discharge them earlier in the day, decrease length of stay, shorten length of stay, earlier in the day discharge, create capacity. That was the strategy. And you see what happened to our 2% data. It goes down to less than 1%. Pretty quickly, just by starting to do some work. But this is getting work done, right? It wasn't just talking about it, it's changing practice. So, and just to give an example, so for this access and flow, the focus was on length of stay and time of day of discharge, and some of the examples of the tools that were developed, and we're still developing tools, right? We developed the concept of cluster meetings every morning. There's a surgical, a medical, and an intensive care unit cluster that gets together that talks about how many beds do we need, how many beds we got, what are we going to do? And they share across services, right? We have a pathway to discharge toolkit. We have whiteboards on the floors. We have before 11 a.m. discharge data, and we call it the BED program, B-E-D, before 11 discharge. We push it, get them home before 60% is the target. We have an electronic system in Emerge that tracks how many hours the patient has been waiting. And it goes red at, I think, 12 hours or something, right? And then it goes yellow, and then it goes red at 18. So in Emerge, you can see who's down. The patients don't get lost, because that's what used to happen. Patient would be there and everybody forgot about him. Clocks tick, 24 hours, patient's still there, everybody forgot. So we have a system in Emerge. We have a daily bed management board now, which is electronic, which talks about, tracks every bed in the hospital. We do demand capacity matching, every ward in the morning. How many coming in? How many beds we got? Do we have a problem? And they have to post their data. So they have to predict their discharges, right? So it's easy to count an empty bed, and it's easy to count somebody who's got a discharge order that's written and signed with the prescription, everything's done, and then there's the ones that maybe are going to go, right? And you need to count them. Some percentage of them are going to go, actually. And so you can line things up. And we do tracer reviews. When we have people that stay longer than 18 hours now, we've moved it down from 24, we review every case and find out why. So every case in Emerge that stays longer than 18 hours, somebody goes in and reviews and says, why did this happen? And we look for the learnings, right? Like what's the problem? What can we fix? Remember, I was back to my thing. We had leadership, infrastructure, structure, engagement. What have we done at St. Michael's around engagement? So I worked very hard to make sure that frontline staff, and that includes physicians, know that this is all about them. So you really have to kind of get them involved, get their hands dirty. So we have working groups and committees that we make sure they're all represented on. We really work hard to encourage them to come up with their own ideas for change, which we then can review, and perhaps some of them will actually do. You have to provide educational opportunities and build capacity through leadership development. So we're just starting an improvement fellowship that's actually going to start in the fall, which is like a program. We're a member of IHI, and we distribute that to our staff. We have something called Safety Net, which is an internet sort of social networking kind of tool that allows staff to go in and talk to each other. And we communicate our successes constantly, and we look to reward people that have done something special. So really try to keep this at the front line all the time. So back to Cotter, we started with make the case, and then get it going, and now make it stick. Right? Because the problem is it can slip back. So the principle that we've adopted here on making it stick is that we need to align all of our quality improvement initiatives with existing structures and processes as much as possible so that you bury it into the organizational culture, right? It has to be, anything new that you do has to get right in there and be part of norm. It can't be outside of norm, or it will slip and slide off. So we redid our corporate strategic plan and put quality in as a major driver right up front, and we actually titled the strategic plan Quality Care Through Knowledge. That's the title. So we just put it wherever everybody could see it as a priority. We have annual corporate objectives, and we align those with the strategic plan, which has quality in it in a major way, and we align that with our quality improvement plan that we now have to submit to Health Quality Ontario. The programs, we have annual program objectives, which are local, and they all have to have quality in them. And I do something called a quarterly President's Report Day, where every quarter, and we did one last week, I spent a whole day, every service in the hospital has to come and present to me for 10 minutes about what they're doing. They always have to tell me about budget, but they all have to tell me about quality, what they're doing on quality. And there's certain metrics that we force them to tell us about, and then they can tell us about whatever else they're doing that, on top of that they want to tell us. And in one day, we sort of hold people's feet to the fire, but also we're able to give messages back and sort of make sure that this is really kind of constantly on everybody's radar screen. And there's some other things we do as well, but those are perhaps the highlights of our Make It Stick strategy. But I think there is some other things you need to do. Actually, just because you created a tool doesn't mean the tool's perfect. And I think one of the things that can happen, and I think it's happened with our access and flow, is we created tools. They weren't perfect, but with all the hoopla and the excitement, people did them anyway. And then they go along for a while, and then all of a sudden, it starts to wear thin on you, right? Because this is not so easy. This isn't perfect, and we don't really like it, and there's a tendency to slip off, and fall back. And all of a sudden, things aren't going the way they were. So I think you have to revisit and look at things and make sure that you've got it right. I think you have to think about your structure and review things periodically to make sure that you have it right. And you can never stop communicating. Right? You just can never stop talking about it. The moment I go to a town hall and don't say something about quality, for sure somebody's going to say, gee, I wonder if he's off it. Maybe it's not important anymore. It just has to be there every time, and you can never stop. So here's an example of slippage. So I showed you great data on emergency department wait times. And 2%. So what we did here, there's a first red line that shows things getting better, light blue, below the line, down below 1%. And you see a second red line. At that point, what we did is we changed the 24 to 18 hours. So the dark blue is now 18 hours. So we want to make it hard, we want to do better. So we wanted to reduce our number of patients waiting in emerge longer than 18 hours to below 1%. And you can see that it's higher than the light blue line that's along the bottom. But then, boom, last fall, the wheels fall off the bus, right? So sustainability, right? This is not stuck. Now, there's lots of reasons that people can bring in, say, well, that was the fall, we had the flu, so a lot of 2-bedrooms became 1-bedrooms for infection control purposes. One of the major floors that is a major taker of patients every day, general medicine. We implemented CPOE. We went live on the floor, so the nurses are all learning how to chart and do orders electronically. So, the eye was off the ball, blah, 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 right? The point is, it got worse. And so in the most recent few months, it's stabilized, but it has not gone back down to those good glory days when it was below 1%. So we're still struggling. So this make it stick thing is real. I didn't actually believe it. You have to sort of experience some of this stuff to sort of realize, this sustainability thing is actually a real concept. You really have to watch out for it. So this is my last slide. So a rule of threes, I'll just say 3 things. Quality improvement is all about change, doing things differently. Change management paradigm for which I would propose to you is take Cotter's leading change book and his 8 steps, and you can make them 3. Make the case, get going, make it stick. Under make the case, capture the hearts and minds. Under get going, leadership, structure, infrastructure, and engagement are what allow you to do this. And the make it stick, you really got to drive this into your culture, right? It has to be, these changes have to become part of who you are to really sort of stand the test of time. And finally, just to make the point that not all quality improvement initiatives are equal, and you need to think long and hard about how many you load onto the organization, in what order and in what way. Some are easier to do than others. I would suggest starting with the easiest as much as possible and kind of moving on to the others. So that's my presentation. I'm happy to take questions. Anton?
Thank you, Bob. We probably have time for maybe 2. I think I can actually walk around a little bit here. Maybe, maybe not. John Rance.
Hi, Bob. Great presentation. Do you think the fact you're a doctor makes it easier? You're in this seat, you're in the corner office. I would guess it probably does, but I would be interested in your views on that.
So I don't necessarily think so. I mean, I think as a doc, I kind of know how docs think, because I guess they think like I think. So I can talk to them. And doc alignment's pretty important. So I think that one piece, I have an advantage over somebody who's perhaps not a doc and has to kind of learn how to interact with docs. Doc alignment's huge here, right? I mean, it would be a whole lot easier if they were our employees. But they're not. And they have huge independence. So getting them on board is crucial. Nothing's going to happen unless they're with you. So the ability to kind of get them on side is big, and I guess maybe I have an advantage there. Otherwise, probably most of it's a disadvantage, right? Spent too much time being a doc and not enough time being an administrator, so I don't know as much as some of my colleagues about good old-fashioned administrative principles.
Bob, Ian Underwood, we're just handing this down the line.
Oh, there you are.
You,
Okay.
you opened by referring to the fact you and your board agreed quality is going to be a major priority, and then we didn't hear about the board. Can you just talk a bit about what has this evolution looked like at the level of the board in terms of how they're spending their time, et cetera? Just what would we see at your board today that we didn't see 5 years ago?
Yeah, thanks for the question, Ian. I didn't talk about the board because Kevin Smith did that, and I thought he did a great job, so I thought I'd just fly by that. But the board's crucial. So the board buying in is really, really important. One of the things that happened is our board quality committee, the chair, we changed the chair, and the person who's the quality committee chair is actually an expert in his previous life on quality improvement. He really gets it. And those meetings have been transformed. So they're more excited. You know, the board members used to love to go to business services because it's the final, you know, they know that. And they hated the patient care committee or the quality committee. Now everybody wants to be on the quality committee because they're so exciting, right? So it's all about data, and it's all about change and process improvement. And the chair of that committee has just transformed the tenor of those meetings and really holding our feet to the fire. So we're talking about real stuff now. At those meetings. It's not show and tell. It used to be show and tell, and it's not show and tell anymore. So, and then what we do is that quality committee, he makes a report to the board every time, and we really bump that up in terms of the amount of airtime he gets. And the other thing we do at the board is I bring stories to the board. And I told you that, I sort of hinted that tend to bring negative stories to the board. Our board tended to have this kind of attitude, oh, you know, St. Mike's is such a wonderful place, there's nothing to do as a board, right? Like, it's all perfect. So when you tell them, well, we had a baby die, it's like, oh, like everybody's on the front of their chair, right? It changes the whole tone of the... So a negative story at the board gets board engagement, and all of a sudden they're in. So we tell stories at the board. Sprinkle it with some good news stories too, right? They're not all bad. But I think telling some bad news stories and having it as a regular agenda item and really giving airtime to the quality committee, which is actually doing real work, is crucial, and that's what's happening.
Bob, the timing is quality one. It's 9 o'clock, so it's my turn. I just have one note. One is this is the last session before September. The second one is some of you will remember the May 5 presentation by Stephen Duckett, which had some controversial points to it. And Stephen actually thought that the press might pick some of it up. He was a little disappointed, and then I got an email from him yesterday suggesting I take a look at CBC. And CBC had picked up a point which then was picked up by every media in Alberta, and the simple point was that politicians were jumping the queue. So if you want to read about Stephen Duckett and his speech at Breakfast with the Chiefs, just Google Alberta Stephen Duckett, and you'll get all you want about jumping the queue. You don't do that. Thank you very much, Bob. We've got a small donation going to the chair for homelessness, and we hope to see you again or someone from St. Mike's next year. Thank you for being our host, and thank you, Bob Hart.
Thank you.